So thank you, Rishi, and everyone. A warm welcome to POSI Orthokids Fellows Teaching Module. And the next module is on patellofemoral instability. The first talk is from Dr. Shital Parikh, who is a very well-known international faculty. And Dr. Parikh uh, is my colleague. He's an alumni of our LG hospital. And Professor Shital is orthopedic surgeon professor in University of Cincinnati, is a co-director of orthopedic sports department and center at Cincinnati Medical Center. And we all have been benefited by Shital's presence as he has expertise and interest in pediatric trauma, arthroscopic surgery, sports medicine. Moreover, he is one of the directors of Patellofemoral International Foundation, and he is a worldwide pioneer on patellofemoral instability. He is one of the lead investigators in Jupiter multicentric study, which is studying patellofemoral surgical outcomes. So it's really a fortune to have him here. We are very fortunate that Shital and his team from Cincinnati visits Ahmedabad, Gujarat every year as a part of the mission trip. And many needy patients and young budding doctors learn from their presence. So Shital, a warm welcome, and kindly share your screen. And we are very fortunate to have you here. Thank you.
Thank you, Maulin, for that kind introduction. Can you see my slides and can you hear me okay?
Yeah, we can hear you, yes.
Okay, so first I would like to thank Dr. Maulin Shah for allowing me to present on patellofemoral instability, which is a very passionate dear topic for me. And Maulin also has a lot of achievements. He has contributed quite a bit to the academics in pediatric orthopedics, including brachial plexus and pediatric trauma. And he has, besides the academics, he's also well known for his extracurricular achievements, including his ability to sing and to write. And this is his book that I was fortunate to get a hold of. As he said, we were trained by Dr. Pankaj Diveta. We belong to the same institution, so we have deep respect for our professor. So the topic today is first-time patellar dislocation. We are going to talk about epidemiology, the non-operative management. Can we predict recurrence after first dislocation? How to treat osteochondral fractures, and then operative treatment. And in the end, I'll discuss a few of my preferences of how we manage it. And I'll also review the literature in the last 5 years to see what's coming. So as far as the epidemiology is concerned, there is increased incidence of acute patellar dislocation and surgical procedures across the US in pediatric and adolescent patients. You can see the graph showing increased incidence. It's a 2.7-fold increase in number of patellar dislocations seen in the ED, and almost 2 times increase in patellofemoral surgery in 10 years. And that is 2004 to 14, and it has continued at the same frequency. Part of it is because of increased sports. Majority of the patellar dislocations happen during sports, non-contact injuries. Also because of increased awareness, increased diagnosis, and improved outcomes of management. This is one of the most cited study when it comes to epidemiology and natural history of patellar dislocation by Don Fithian from San Diego. The study was done in 2004. It included prospective enrollment of 189 patients, and they found that females 10 to 17 years of age had the highest risk of dislocation, and patients with a prior history of dislocation had 50% rate of redislocation. So that makes it one of the most predictive factor of recurrent dislocation is a history of prior dislocation. Our Jupiter database shows a similar histogram. This is 2074 knees, and you can see that Between the ages of 13 and 18 years is majority of the dislocations, slightly higher in females. It's 63% to 37, or if you look at other studies, around 60% females, 40% males. So let's look at first-time patellar dislocation who do not have any fracture and have no history of a contralateral instability. So this type of presentation is very uncommon. Most of the patellar dislocations reduce spontaneously, so you don't see a dislocated patella like this. But if you do, then it's very easy to reduce the patella. You just calm the patient. If needed, you can give sedation. You gradually extend, and sometimes maybe a gentle push to get the patella reduced. It's not difficult once the patient is either sedated or is calm and relaxed. But sometimes you would see irreducible patellar dislocations like this. This is quite uncommon. This is actually a rotational instability where the patella has spun out of the trochlea. And this was a recent case that was seen by my partner, Dr. Wall. And this is one of the cases that I had encountered about 7-8 years ago now, where the patella had spun out. If you look at the MRI, it had the quadriceps mechanism had declaved, and that required open reduction to reduce the dislocation as well as to stabilize it. But this is kind of rare. It's not very common to see it. When you do not have an effusion and there is no major cartilage injuries on MRI, then treatment is conservative. So we'll look at, how do we treat these patients conservative? This is Petri Silanpa's group in Finland that I had the pleasure to visit. Their group, they did a randomized study comparing a patellar stabilizing motion restricting brace versus just a neoprene knee sleeve. And what they found is that there is no difference in failure rates based on the bracing. Motion restricting brace actually had more quadriceps atrophy, less range of motion, and worse functional outcome at 6 weeks, which means that we don't need to immobilize these patients. There have been other studies that I have not put on the slides just because of time constraints, but study comparing cast versus taping has shown that cast is worse as far as outcomes are concerned, because anytime you immobilize these patients, it doesn't take too long for atrophy of the quads, which leads to worse outcomes. There is not a whole lot of literature on conservative management of first-time dislocation, but there are consensus statements. These were statements into 2024. And there are two parts, and if you are managing first-time patellar dislocation, you can read their statements. We did a similar study in the US where we did consensus-based guidelines from the PRISM group, which is the patellofemoral research interest group, and published in the same year, 2024. And some of the findings suggest that patients are allowed weight bearing as tolerated, physical therapy is recommended, and return to sports is allowed after 2 to 4 months. But overall, there is a consensus that patients are immobilized for a very short time, only till their pain and swelling subsides, usually 1 to 2 weeks, maybe an immobilizer, but after that, we need to start moving them. If we look at the long-term outcomes of knee brace versus operative ligament repair in children with first-time dislocation, this was a recent study this year published by Murray in Sweden. And they showed that the knee brace at 10 years, if you treated a patient with a knee brace, there is an 80% chance the patient is going to have a redislocation. And then if you did an MPFL repair, it did not make it any better. It was 62%. Statistically, there was no difference between these two groups. So the authors do not support either treatment options. So 80% redislocation at 10 years, out of which half of them, or 52%, occurred in less than 2 years, and then 28% after 2 years. If we look at this study by Bob Magnuson in Columbus, who is also part of Jupiter's study, and they looked at the patellar dislocations that did not redislocate. And what they found is that if you did not do surgery and if they did not dislocate, does not mean that the patients are doing okay. Only 26.4% of the patients without further dislocation reported that they were able to return to desired sport activities without limitations following the dislocation. So these patients can have apprehension, they can have functional limitations, They can have pains, they can have swelling, or fear to do the routine activities, which doesn't allow them to go back to the same intense level of sports that they want to go back. Which means that patients, even if they don't dislocate, does not mean that they are doing fine. Now, the main thing, the redislocation, can we predict recurrence? We looked at our cohort, and these are the 4 risk factors that we found that include skeletal immaturity, contralateral dislocation, a Cotton-Duchamp index more than 1.45, which is patella alta, and trochlear dysplasia. And if you had all 4 risk factors, or 3 out of 4 risk factors, your risk of redislocation is more than 75%. So these patients, we do recommend surgery, even if they are first-time dislocators without an osteochondral fracture. And a lot of studies have looked at the predictors of recurrent instability, and a couple of factors have been common in all studies. And one is young age, so skeletal immaturity or young age, and second is trochlear dysplasia. So if you have only those 2 factors, if there's a young patient with trochlear dysplasia, there is going to be at least a 70 to 80% chance the patient is going to have a redislocation. The way we describe skeletal immaturity is based off on MRI, looking at the proximal tibial physis, and this was a study from the Jupiter group, that if the proximal tibial physis, the central part of it, once it starts closing, then that is considered to be skeletally mature. When we looked at the prediction of contralateral patellar instability after ipsilateral dislocation, and this was published this year in AJSM, and we found 5 risk factors, including skeletal immaturity, a Beighton score more than 4 out of 9, which is hyperlaxity, recurrent ipsilateral dislocation. That means if a patient has recurrence in one knee and they have trochlear dysplasia and alta in the same knee, there is a very high likelihood that they're going to have issues with the other knee. And this is the graph. So if you have all factors, there is a 77% chance you're going to have a dislocation of the other side. Now, why is this important? This is important because a lot of the factors that we can correct by minor procedures, and one of them is guided growth, it is time sensitive. That means that there is a window that we can do this procedure beyond which they would require an osteotomy. So if you know that the patient has significant risk factors and has a genovalgum, even if we do not do any surgery to stabilize the patella, we can at least offer them guided growth in patients who have instability. The other reason that it's important is that if you can predict that the patient is going to have a contralateral instability, that means now the patient has bilateral instability risk factors, then your management may be a little bit more aggressive rather than trying to manage them non-operatively for the ipsilateral side, because you know that the other side is also prone to redislocation. We looked at the novel machine learning score using 3D bone position from MRI, and this was done to predict the outcomes after non-operative treatment for a first-time dislocation. And then there was a score that was established. This was published last year. And then there were these factors that if you look at the 3 sections here, the blue one is a control. So we had control knees and we had patients who had instability, and they were all mixed and given to the AI group at Stanford. And they were not told which patients had instability and which patients were control. It was kind of a mixed cohort. And we said, just analyze it. And what they found is that if on the axial view, you had a little bit more patellar translation, if you have patellar height on the sagittal view and some rotation on the coronal view, those patients had poor outcomes after non-operative treatment. So it was a little bit different risk factors than what we normally assume. And there is, I'm pretty sure with more AI and more machine learning, as more data is input, we'll come across novel factors that we have not considered yet to predict these poor outcomes. Now, if you have a first-time dislocation and you do a non-op treatment, but the patient either has recurrent instability or has symptoms after 4 months, and those symptoms are at the bottom, subluxation, pain, effusion, fear, or inability to return to activities, how do we treat those patients? So when we look at a randomized study comparing non-operative treatment with MPFL reconstruction, this was the first RCT comparing non-op with MPFL reconstruction in 2012. They found that non-op group had 35% redislocation rate, whereas MPFL reconstruction had 0 redislocation rates. And the score, the patient-reported outcome score, were good to excellent in 71% of patients in the reconstruction group versus only 25% in the non-op group. And subsequently, there have been several studies, and this study done by Eric Strauss, he's again a member of the Jupiter group out of NYU. They collected all the randomized studies and did a meta-analysis. And what they found that when they did a subgroup analysis of first-time dislocation, the redislocation rate was significantly lower in the MPFL reconstruction group compared to the MPFL repair or non-operative group. So this is combining all randomized studies. So this is pretty good evidence. Same thing, the patient-reported outcome scores were significantly better in reconstruction group compared to the MPFL repair group or the non-operative group. And what this tells us that repair is not a great option. It is, most of the studies show that repair and non-operative treatment are almost the same. They don't change much. So if you had to do anything surgically in patients with recurrent dislocation or even first-time dislocation, then reconstruction is the way to go. Now let's look at the third group, which is first-time dislocation with intra-articular fractures or those who had contralateral patellofemoral instability. I would say about 1/4 of the patients, or 25% of acute first-time dislocation, have an osteochondral fracture. If we look at these, the previous Cs that have been published, the location is that 75% of the time, or 3/4 of the time, it's from the medial facet of the patella. 1/4 of the time, it is from the lateral femoral condyle. And sometimes it is from both. It's not very common to have fractures in both areas, and sometimes in trochlea, which is also not common. The radiologic risk factors, this was the Jupiter study last year. And when we looked at the risk factors of osteochondral fractures in patients with first-time instability, we found that the odds of having an osteochondral fracture was much more with a first-time dislocation than those with recurrent dislocation. One of the theory is that first-time dislocation, especially if you have a contact injury, takes more force to dislocate the patella that might lead to a fracture, compared to someone with recurrent dislocation may already have a torn MPFL or may have underlying risk factors, which makes it easier for the patella to dislocate, and that saves them from an osteochondral fracture. Patella alta was protective of osteochondral fracture, which is understandable, and the lateralized tibial tubercle was a risk factor for osteochondral fracture. We need to look at some equivalence of bone bruises, cartilage fissures, medial patellar avulsion fractures that you see here on both sides. These are not intra-articular, they're extra-articular avulsion fractures. Fractures of the non-weight-bearing surface of the lateral femoral condyle and bipartite. And I'll just give an example of each of this equivalence and why it's important. First are the characteristic bone bruises, which is the medial aspect of the patella and the lateral femoral condyle. A lot of times the MRI reports these contusions or the bruise pattern as subchondral fractures. Patients read the reports and a lot of times they think that they're coming for fracture treatment. And it is important to recognize that this is a pathognomic sign of patellar dislocation, very important for us because a lot of times in acute presentations with knee fusion, it will be difficult to examine the patient. So you are relying a little bit on the MRI. And in those cases, you're not really sure whether you have an ACL tear, whether you have a patellar dislocation. If they don't have a bone bruise pattern and the patient is complaining of instability, you need to be cautious. We have had several patients who would come saying that, oh, my patella dislocates, but they never had one objective sign saying that they had instability. So then to initiate treatment, especially surgical treatment, can lead to a pretty dangerous path. I would try and make sure that your diagnosis is correct, and these bruises can help make diagnosis. As far as the fissures and the cracks are concerned, this is a landmark study of in 2003, where they looked at the cracks and cartilage defects and osteochondral fracture with cracks. So a lot of times you would just have fissures or just have cracks, and the natural history of these cracks is that they don't progress if you stabilize them. But if you don't stabilize them, then these cracks can progress. And you can see some of the cracks besides the osteochondral fracture. We do some T2 mapping on MRI, and that can help us know the cartilage injury because these MRI sequences are very sensitive for cartilage, and it can detect low-grade cartilage injuries. So this is part of a research study of doing some T2 mapping on MRI to evaluate the cartilage, but a lot of times the X-rays on MRI don't pick up the subtle cartilage injuries that these patients sustain. The medial patellar avulsion fracture, as seen here, and it was studied by Simon Donnell, who has retired. He was at Norwich, and 35% of the patient has this medial patellar ossicle. They all are from the distal half of the patella. Now, if you remember the anatomy of MPFL, MPFL inserts in the superior two-thirds. So most of the insertion is in the superior half, whereas these patellar ossicles that you see are most of the time from the inferior aspect or the distal aspect of the patella, and they represent an avulsion of the medial patellotibial ligament, not MPFL. It is commonly thought that they represent MPFL injuries, but they represent medial-sided injuries, but not necessarily MPFL injuries. They excised 10 out of 12 ossicle when they were doing the surgery. For stabilization, we usually ignore the pieces. We don't excise them. We just leave them. They come in the way, then you can remove them, but you don't try to chase them. The other important thing is that when you have an osteochondral fracture on the axial view, then that also makes the axial view really important because it's a diagnostic sign if you have this medial avulsion. But it is very rare to have an intra-articular osteochondral fracture when you have a medial avulsion fracture like this, because you would not have both at the same time. It takes a lot of force for the dislocation to pull a piece like that, which saves them from an osteochondral fracture. So it kind of gives you a little bit of a cushion, or if you don't have an MRI, then that's fine, because most of these fractures, when you see it on an X-ray, they would not have an osteochondral intra-articular injury. You do need to differentiate it, avulsion fracture from an osteochondral fracture, because osteochondral fracture may appear to have a small sliver of bone on the X-ray, or maybe pure chondral injuries, and they are very important to be fixed. I was referred this patient by one of the primary sports doctors, first-time patellar dislocation, and was referred for this osteochondral fracture. Now, if you look closely, this osteochondral fracture is actually on the lateral side, whereas most commonly osteochondral fractures arise from the medial side. This is the MRI of that patient showing the osteochondral fracture. If I took a contralateral X-ray, and you can see that this was not an osteochondral fracture, it was actually a bipartite patella, okay, which does not need surgical treatment unless it's significantly symptomatic. So you have to be careful when you analyze the X-rays. Anything on the lateral side or in the supralateral aspect of the patella, they are normal variants, including bipartite or multipartite patella. If you do have an osteochondral fracture, what you're going to do? Either you're going to do nothing, or you're going to excise it, or you're going to fix it with screws, pins, or sutures. And let's look at some of the treatment options. So when you have less than 1 centimeter fragments, it's okay not to chase them. That means that it's okay not to do an arthroscopy just to go after 1 centimeter fragments. They frequently get stuck to the synovium, as you can see here on the bottom right, and this is one of my patients. But I've seen that because osteochondral fracture is an indication for surgery, does not mean that if you have small fragments, that's an indication for surgery. What it means is that if you have a big piece that needs to be fixed, then that's an indication for surgery. But smaller pieces can just heal on its own. So this patient had recurrent dislocation, and I went in for MPFL reconstruction. I always do an arthroscopy, and then this small piece was already healed to the synovium, so it wasn't a free-floating loose body. This patient came to me about a year after the dislocation and was referred, for arthritis. And they had not recognized this piece that is sitting in the posterior aspect of the joint from the dislocation. And you can see that it's a pretty big fragment. When I went in with the scope, I removed that fragment, and it was really poor quality of chondral fragment. And I could not reattach it because it was, I could easily bend this piece. So this is one of the few instances where I excised it, but you can see it's a very big piece from the trochlea. So this might need cartilage restoration procedure in future. If you look at a lot of studies or the several studies comparing excision versus fixation, and these are the ones that showed no significant difference, and these are the papers that showed that there is difference, I would always consider fixation over excision. And these are a list of the studies that shows the fixation using either pins, sometimes sutures, and sometimes screws, and their results. Bioabsorbable implants are very popular. The advantage is that they are low profile, easy to use. They are MRI compatible, and it's a single surgery. That means you don't have to go back in to remove them. But the disadvantage is that the same advantage that you can see that they can be you can get an MRI in spite of having a tack. It's also a disadvantage because if these tacks, if they back out, you cannot see them on an X-ray, and they can damage the other surfaces. So it can also lead to synovial effusion when you use increased number of implants, and if you have if you have absorption of those implants, it can lead to fusion, and these can break and these can loosen. If you look at this study where they were looking at the second surgeries performed on the knee, you can see that the second surgery, 4 out of 11 patients, the surgery was done to debride a biodegradable implant. So it is not benign. You know, these implants can back out, can irritate the other surfaces, opposite surfaces, and they can also lead to recurrent effusion. Metal implants, they are headless compression screws. The advantage is that they have really good mechanical compression. They are seen on radiographs. They are MRI compatible if you use the titanium ones. For a long time, my preference had been to use the metal implants. I still use it if I see a bigger chunk of bone in the piece. The disadvantage is that they do need second surgery and they can erode the cartilage. So if you look at this fragment, it had bone, and I fix it with screws, and then I'll go back in at 3 months to remove it. Now, if you don't remove it, that's a problem. The problem is not that the implants get loose, but the problem is that this cartilage can delaminate. And if the cartilage delaminates, then it can expose the screw head like seen in this patient here. You can see that the screw heads are prominent, and what they have done on the tibia is to create a trough when you go in. That's something which is avoidable. If you remove them timely, if you remove them at 3 months and don't keep them in for longer periods of time, then you can avoid these kind of injuries, iatrogenic injuries. When it comes to the ORIF of condyle-only fragments, one thing is that in children, especially younger patients, don't excise the condyle fragments thinking that it's just cartilage and it's not going to heal. Look at all these studies. They all are trying to fix condyle fragments, and they all have been successful. And there have been several studies showing that this condyle pieces may have a single layer of, osteocytes on the backside, which is enough for them to heal. And if you look at this diagram, this figure here, there's a big osteochondral fragment which was fixed, and it went on to heal. Multiple studies show this is a MRI at follow-up, which shows that the piece has healed. This is a multi-center study which showed 15 patients, and all were fixed with bioabsorbable implants, and MRI were done at 1 year. And then most of the patients had healing of the fragment. And this is an example from that article. You can see it's a cartilage-only piece, condyle piece, and it was fixed. So in short, don't excise this condyle-only fragments. If they are big enough, if they are more than a centimeter or more than 1.5 centimeters, there is a threshold between that. It's a gray area between 1 and 1.5 centimeters, but try and fix as many as you can. How about suture fixation? This was a study about 18 patients, PDS sutures, and they were tied on the top part or the dorsal aspect of the patella. I'm gradually leaning towards suture fixation. I like fixation. This is a study from the Texas group, Henry and Phil Wilson, who are part of Jupiter study. And they published this osteochondral fracture. 17 patients had full union, 2 had stable union, and none had non-union. And this is using suture bridge fixation, which is my way of fixing as well if I tend to use sutures. What about patellar stabilization? Now, in this one of the studies, it has shown that when you have an osteochondral fracture in a first-time dislocation, 97% of the time the patient is going to have an MPFL injury. So most of these patients with first-time dislocation already have an MPFL injury. So what are we going to do if we are going in to treat the osteochondral fracture? Should we just address the fracture and not stabilize the patella? Should we repair the MPFL in the medial structures, or should we do an MPFL reconstruction? So the San Diego group had two articles. One was looking retrospectively in their cohort. They had 41 patients who underwent surgery for an osteochondral fracture. And those who only had an osteochondral fracture treatment, that means that there was no stabilization done, there was a 61% recurrent instability rate at a mean of 4 years. If they did do an MPFL repair, it did not change much. Again, another study which shows that no treatment or repair almost has the same rates of failure. So they recommended MPFL reconstruction, not repair. But in this study, they did not study MPFL reconstruction. They just recommended. In a follow-up study, they looked at MPFL reconstruction versus repair or doing nothing, and they found that the MPFL reconstruction resulted in a 5-fold reduction in recurrent instability and reduced the need for subsequent surgery and improved return to sports. So this is a list of the concomitant procedures that I usually do when I'm treating skeletally mature patients. It shows the percentage and the indications of the treatment. So I do guided growth 15% of the time, and my threshold for guided growth is pretty low. If the weight-bearing line is just lateral to the lateral tibial spine, for me, 3 to 5 degrees of genu valgum is enough to consider guided growth. I look at the lateral distal femoral angle. If it's less than 85, normally it is 87. If it's less than 85 and the weight-bearing line is in the lateral aspect of the joint, then I would do a guided growth. Lateral release, I do 20% of the time, and the indication is a patellar tilt of more than 20 degrees on the MRI, which is not correctable to neutral with the patient under anesthesia. And a distal procedure, 10% of the time, especially those who have a jumping J sign, that is when I try to distalize with a Rube Goldthwait procedure. And then a fascia sparing MPFL reconstruction. So my preference is in this case, you can see there is an osteochondral fracture of the patella, and it is involving almost half of the articular surface of the patella. So I've done it in 2 stages. I tell the patient that you have 2 problems. You have a fracture and dislocation. I'm going to do it in 2 stages. So first stage, I would do an ORIF of the patella. And the second stage, this is the ORIF with the headless screws. And in the second stage, I would go in, I would remove the hardware, and I will do an MPFL reconstruction at 3 months. The reason to do it this way is because if I do an MPFL reconstruction the first time, then it's difficult to go from the medial side because the reconstruction would prevent a medial-sided arthrotomy, which is what I prefer when I try to fix it. So I fix it first, then I go back in, remove the hardware, and then I do an MPFL reconstruction in the second stage. Here is an example of an osteochondral fracture treated with screws, and as a second stage MPFL reconstruction. It's a little bit different when the fracture is on the lateral femoral condyle. In that case, I would do both at the same time because if I have to go in to remove the hardware, it would not come in my way. So I will make 2 incisions. One is for MPFL reconstruction and a smaller incision on the lateral side to fix the lateral femoral condyle fracture. As you can see here, it doesn't come in the way of my MPFL reconstruction. So I do a single stage when it comes to lateral femoral condyle osteochondral fracture, concomitant MPFL reconstruction. To summarize the treatment of osteochondral fracture is that non-op management can be tried if you have a small fragment, less than 1 centimeter, but every effort should be made to perform fixation of an osteochondral fracture. The options are, it's your choice. You can use chondral-specific implants, suture fixation, headless screws, and no options has shown better competitive outcomes. And if you treat them operatively, patients with an osteochondral fracture and an MPFL injury, they should undergo MPFL reconstruction. MPFL repair is not recommended. And let's look at a couple of cases. So this is an 11-year-old female who twisted her right knee playing soccer, first-time patellar dislocation with an effusion. So when they have an effusion, you should get an MRI. We get MRI on all patellar dislocations now because of several chondral injuries that have been noticed, even in absence of significant effusion. So in this patient, you can hardly see the osteochondral fracture, but if you look closely, there is a small sliver of bone there. If you do an MRI, you can see that it's a pretty big fragment, 28.2 millimeters. That's half of the lateral femoral condyle, as seen on the bottom right MRI slice. The patient had genu valgum, and you can see that this is not significant valgus, but the weight-bearing line is in the lateral compartment, lateral to the tibial spine. The lateral distal femoral angle less than 85. So I would consider a guided growth for this patient. I look at the left-hand X-ray to make sure that they have enough growth. We need about 1 year of growth when you're doing guided growth to achieve the correction that we need. So what do we do? 11-year-old girl, first patellar dislocation with an osteochondral fracture from the lateral femoral condyle, genu valgum, more than 2 years of growth remaining. So the first step, I took her to surgery. First step is to do the medial hemiepiphysiodesis using transficer screws. And we have had good success treating genu valgum with screws. We published our results, and then we did a multi-center study, and those results were published a couple of years ago doing MPFL reconstruction, and simultaneous guided growth doesn't change or doesn't alter the results of MPFL reconstruction. You can also use tension band plates when you're doing MPFL reconstruction, though if you look at this cadaver study, the MPFL does come in the way of your medial-sided plate. So most of the surgeons have spoken with who do use the plate, they put the MPFL on top of the plate, and then they remove it by going underneath the MPFL. I don't like the idea of doing, the plate around the same area of the MPFL, and that's why I choose to use screws instead of the plates. Then I did a lateral parapatellar arthrotomy, and I did an ORIF osteochondral fracture using 2.4 millimeter headless compression screws. And then this is the fluoro shot. I used about 22 to 24 millimeter length screws to just stay short of the physis, as seen here. These are epiphysis screws. And then I did a physis sparing MPFL reconstruction. This is the way I do it: single tunnel in the patella and interference screw on the femur. I use a Gracidis allograft. You can use autograft as well, and studies have shown no significant differences between graft types. This is MPFL reconstruction showing the femoral positioning of the interference screw in the epiphysis. The follow-up is critical to prevent overcorrection. Every 3 to 4 months, we'll do a full-length X-ray. And this patient had the screw removed, including the intra-articular screws, as well as the transficer screws removed once it was corrected. And I just saw the patient 2-year follow-up, and she had returned to full sports without limitations, no issues, no tenderness, and you can look at the neutral alignment of the leg. Another case, 12-year-old girl, first-time patellar dislocation. Again, you can see the osteochondral fragment in this area here. This involved almost half of the patella and a big fragment. We did an arthroscopy, but when we retrieved the fragment was in 2 parts like this. And as I said, I would not consider excising these important pieces of osteochondral or cartilage. So here I fixed it with screws, with suture anchors and sutures. I use the 2.9 push lock suture anchors from Arthrex. I have no conflict of interest. There are a lot of other suture options available. I usually load them with 3 Vicryl O sutures and then do a zigzag pattern to fix it. And you can see that I've used 3 anchors here, and we have good fixation of the comminuted fragment. So what has changed in recent years when it comes to first-time dislocators? This is the Jupiter study data. Of the 720 knees in first-time patellofemoral instability group, 49% underwent surgical treatment right from the beginning. Half of it because of osteochondral fracture, 35% because they had contralateral instability. Another 81 patient had redislocation, underwent surgical treatment. So if you look at the entire cohort of first-time dislocators, 60% underwent surgical stabilization. If you ask my opinion about future, what is going to happen, this number is going to rise. The 60% may go to 70 or 80% as we have more follow-ups, and we recognize that redislocation is not the only outcome. The other patient-reported outcomes and return to sports, these are also important. And it is going to drive towards more surgery for first-time dislocators, more MPFL reconstruction-based surgeries. We also found in this study that the number of patellar dislocation event is associated with increased chondral damage to the trochlea. And here, we enrolled 938 knees, and we divided them based on the number of dislocation, whether you have the first-time dislocation, 2 to 5 dislocation, and then more than 5 dislocation. If you had more than 5 dislocation, there was a threefold increase in the incidence and severity of chondral injuries. And there is a caution regarding prolonged non-operative treatment. So if you have a dislocation and then a repeat dislocation, don't just ignore or say that come back later, or if the patient wants to get surgery later, I would strongly urge to fix it, because more episodes they have, more are the chances they're going to have chondral injuries. If you look at this table, chondral injuries combined in patella and the trochlea, and these are 3 groups, first time, 2 to 5 dislocation, and more than 5, you can see that there is consistently increasing involvement of cartilage lesions. It keeps on increasing the more number of dislocations you have. We also looked at the quality of life and cost effectiveness of treatment in first-time dislocation. And what we found is that operative intervention is more cost-effective treatment for first-time and recurrent patellar dislocation at 5 years post-intervention. So this is looking at some complex statistical analysis and looking at cost effectiveness. If you treat them early with surgery, it's more cost effective than treating them later with surgery. So what has changed in my practice? We get MRI on all first-time dislocators. We do not immobilize them except for the first week, sometimes 2 weeks if we have significant pain, swelling, and limp. But we use a patellar stabilizing brace, which is not motion restricting. It's more like a sleeve. We have very low threshold for surgical treatment if they have 3 out of 4 risk factors, or if they have contralateral instability or osteochondral fracture, then we would recommend surgical treatment. I got very low threshold for guided growth. As I mentioned, LDFA less than 85 degrees, I would consider guided growth for these patients. I like suture-based fixation. I moved away from the screws in the last couple of years, more suture-based fixation for osteochondral fractures so that I don't have to go back in to remove the screws. And I think that they give enough compression for the osteochondral injuries to heal. Okay, so thank you for your time. And we have another, I think, 5-10 minutes if you have questions.
Yeah, so that was a great talk, Shital. And now the subgroup of patients which you have described in your studies, they mostly are the sports injuries, right?
Not necessarily. Like, a lot of these patients have non-contact. So rather than the mechanism of injury, the way it is important is to know whether it was contact or non-contact, rather than it was sports or just happened with, just going down the stairs or just, dancing or, doing daily activities. Because the contact injuries are the ones where it takes more force, you have more osteochondral fractures, and you may have normal anatomy. So I do ask the history, because if there is a contact, those patients are more likely to do well with conservative treatment because the anatomy may be normal, versus if they have a non-contact injury, that means that they had underlying risk factors and they are more prone to recurrent dislocations. So I think contact versus non-contact is more important than sports versus no sports.
Yeah, because there are a few patients where they have first-time dislocation. Now they have sustained injury with a domestic fall, and they are not into sports career, where we have done one side MPFL reconstruction, and we suggested that the child might need on the opposite side also prophylactically. But then they do strengthening, and so those are the cases where we keep them in close observation and inform families that they might need. But many of them over a few years now, they are adults, and they have not required because they are not into
So
this.
that is, yeah,
Yeah,
that is true. So when you look at the instability age range, right? So once you cross 25, the chances you're going to have issues with instability, they go down because the joint, tends to get a little bit stiffer with age. So less than 25 is considered to be a criteria for or a risk factor for instability. But if if they can pull it off till 25 years of age without having recurrent episodes, then that's fine. They might not have issues, but you have to be careful because even if they have subluxation, they may wear down their joint. So only if they have no issues like no apprehension, if their anatomy is normal, and no symptoms, those are the patients you can observe. But as I said, especially if they had a contralateral side already done, my threshold to treat them, is very, very low. My threshold to treat them surgically is very low.
yeah.
Uh,
Kalpesh, do you have a question?
yeah. So, Shital, it was a wonderful talk. And as you described, there were four independent risk factors for your first time patella dislocation. You have not mentioned about the TTTG distance. So, lateralized tibial tuberosity is the independent risk factor now, or you don't consider it? What are
So
the
it is a risk factor to for recurrence, but not a risk factor that needs correction because we were more geared towards pediatric patients. You can't do a TTO on these patients if they have open physis. So I didn't discuss it. But the other reason I did not discuss it is that there are more studies coming out, including our Jupiter 4.0, which is isolated MPFL for all patients irrespective of TTTG distance. And we have significantly low recurrence rate, or it's comparable to MPFL with TTO. We think that most patients do not need a tibial tubercle osteotomy, even if they have increased TTTG. And there have been several studies, not just our study, several studies that have reported that you do not need a TTO. You do fine, even if you have increased TTTG distance, you do fine just with an isolated MPFL reconstruction. It may be that if you have a lot of risk factors, if you have high-grade trochlear dysplasia and ALTA and TTTG is increased, then you might have to do a tibial tubercle osteotomy, but just having increased TTTG distance is not considered to be an indication to do a tibial tubercle osteotomy. It is contraindicated in immature patients anyway, but even if they are skeletally mature, we are not looking at it. The other thing I did not bring up is that cost effectiveness study that I had just put the slide. In that same study, what we found is that if you do in this study, we found that if you do a MPFL reconstruction versus MPFL reconstruction with a TTO, MPFL reconstruction was more cost effective at 5 years compared to MPFL with TTO. Okay. So, and doing a tibial tubercle osteotomy is not without risk or complications. We have seen significant, either you can have a non-union, you can have, restricted weight bearing, you can have, hardware issues like removal of hardware after TTO is healed. So it is not that benign of a procedure that it is perceived to be. So we do tibial tubercle osteotomies if they have multiple risk factors in revision setting or if it's significantly abnormal, but most of the time, no, we are not doing it just isolated MPFL.
excellent? Second thing, can you throw some light on the technical aspects of the MPFL reconstruction? What tension amount one should put while fixing the graft? And second thing, in a open physis, the point, the Shortle's point, is very near to the physial plate. So how we can avoid while putting the interference screw? So some technicalities can you discuss in this forum?
Yeah, no, those are great points. So, first, tension wise, so ideally the MPFL should not be tensioned. Okay, so MPFL should not be used to pull the patella in the trochlea. Your tracking should be normal, and then MPFL is placed to prevent it from going lateral. Okay, it should not be used to pull it medially. So the way to avoid putting more tension, because if you have more tension, you can have iatrogenic medial instability, is to flex the knee. Because if you flex the knee, I usually flex 60 degrees. If you flex the knee, then the patella is constrained by the trochlea, And then when you fix the femoral interference screw, you cannot pull the patella medial, okay, because now it is constrained by the trochlear border. So that is how I would do it, is I pass my sutures through the femoral tunnel. I clamp them with the knee flex at 60 degrees. Before I put my interference screw, I extend the knee and I check and make sure they have 2 quadrants of medial and lateral translation, because that is normal. You don't want to over tighten it. And then I would flex it again and then put my interference screw so that I don't advance the graft and I don't pull the patella medial. So that is the first point. The second point about physis sparing MPFL, when you look on the lateral view and you mark, you can blindly ignore the physis and just put your adult Shital's point. It would be exactly on the physis on the lateral view. But when you check the AP view, you're going to be below the physis. That's because of the cup-shaped physis or the undulating nature of the physis. Then it is important on the AP view, your trajectory, how you're going to drilling. So starting point, you do it on the lateral view, and because you want to mark the Shital's point, but the trajectory, you need to do it underfloor on the AP view. Make sure your trajectory is a little bit inferior so that you're not touching the physis, you're staying away from the physis if you're doing a pull-through technique. If you're just doing femur first, where you're putting an interference screw in the femur first, then it's just a matter of drilling a socket, which can be inferiorly directed. But starting point on the lateral view and drilling on the AP view would be the safe way to do it to save the physis.
Now, a couple of quick questions. Ashita, I saw that osteochondral fragment, which was a 2.8 centimeter distance, and you use 5 screws. So, I mean, isn't it why you need to use this many screw, and is lesser number of screw won't be enough, or what's the?
So the thing is that you need compression along this. I know when you use less number of screws, you have to then spread it out a bit. This 2.8 is a pretty big piece. Like if you have a 1.5, I would say you can use 2 or 3 screws. 2.8 is, one of the biggest pieces that I have seen, so that would take more screws. I have had patients where if I put less number of screws, some part of the fragment would heal and some would not heal. The one which is not compressed would not heal. That is another reason I like the sutures better, because sutures span across more of the surfaces and they give uniform compression. So I'm using more suture anchors now, unless it's a big bony piece. Then I like bone-to-bone fixation. Just like for any fracture, I don't like sutures for bone fixation, like a fracture fixation. Then I would put screws. But yeah, the number of screws is based on the size of the fragment, and this was one of the biggest pieces that I've treated, like 2.8 centimeter piece.
Another question which comes to my mind every time I see this slide of MPFL anatomy, that we have been doing lots of growth modulation with 8 plates, and I know I've heard Peter Stevens, Cummings Kids, and even Bill Cole, and they used to tell us that whatever you can pick up in your forceps, you release it and put your plate. So are we damaging MPFL anytime while doing growth modulation? I remember one of the case reports of Patella dislocation after medial 8th plate by, I think, Jayant presented it. But we do tons of this. So, and then
I don't, the thing is that in patients who don't have instability, right? If you do a plate, I don't think you're going to be, so there is a Bachman study, which is based on cadavers, where they did show that, yes, if you put the plates where we normally put the plates, you are going to damage the MPFL. And there is also risk of damaging the capsule. Like half of the plates were intra-articular, or you were damaging the capsule, and then a lot of the times. But that is a cadaveric study. And then if you don't have instability, it's unlikely. So that means that if you don't have instability, your anatomy is going to be normal. You don't have risk factors. It's unlikely that even if you damage your MPFL a little bit, it's going to be an issue. So just for example, if you have a knee dislocation, okay, not patellar dislocation. If you have a knee dislocation, those patients, they have a normal underlying anatomy, like, trochlear groove, patellar height, and everything. A lot of these knee dislocation would have an MPFL tear, but you are not treating MPFL when you're treating knee dislocations. And they do fine. They don't develop instability. Most of the patients don't. And the reason is because their anatomy is normal and the MPFL would heal. So I don't think that, even if you damage the MPFL, I don't think you're going to have instability unless you have underlying risk factors.
Now, the last question from Dr. Tashfeen from Bangladesh. What are the post-operative complications we may encounter after MPFL reconstruction?
So the most common complication is recurrent instability, and the most common reason is femoral tunnel malposition. So if you don't position it in the correct, like most common malposition is proximal and anterior. So if you don't put it in the right location, then recurrent instability can happen, especially in a kid who is growing. The MPFL can stretch, and if it's not in a normal position, it is going to stretch more. So that is number one complication. Second complication is arthrofibrosis. That's why you want to start moving these kids early. We have not had, any arthrofibrosis, like established arthrofibrosis after MPFL, because we are very aggressive with early manipulation if needed. And very aggressive with post-op physical therapy. And the third is patellar fractures. So you want to make sure that when you're drilling in the patella, you don't go beyond 50%. We just stick to the medial aspect of the patella with a single tunnel. You never go transverse. Don't drill more than 4 mm tunnels. And if you're at all concerned about it, that means you're not doing enough, then use suture anchors or use MQTFL, which goes around the quad tendon. If you're concerned about fracture of the patella, or if you have really small patella, or if you're doing revision cases, there are options of not drilling in the patella.
That was a great talk, Shital, and a nice discussion. I thank for your time. And the
Thank you.
next week we'll have extension of the same with the recurrent patella dislocation and what are the management, and Professor James Hui from Singapore will be there, and we'll be glad if you can also be present there so we can have some intricate discussion. Thanks,
Sure.
Dr. Kalpesh Bhai, for your interesting questions. Thank you, everyone. Have a great day. See you next
Thank
week.
you.
Thank you.
Okay. Bye.